Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And we have here a case of a patient who attended with a blocked right ear, and as you can tell, their earwax is very soft and wet and loose, and we're going to try and remove this without reverting to microsuction. And the reason for that is that this patient suffers from really severe debilitating tinnitus in this ear. And sometimes patients who suffer from tinnitus, if they undergo microsuction, their tinnitus can spike and be exacerbated. There's no guarantee of that. It doesn't mean that everyone who suffers from tinnitus is going to experience a heightened sensation of the tinnitus post microsuction procedure. But if it is all avoidable, it's worthwhile trying to remove it mechanically. So when we say mechanically, using instrumentation like the angled right Curette in this instance, or an ear hook or forceps. So you're just mitigating that potential risk. Now, what's tinnitus? Tinnitus is any sound really that originates from within your ears or your head. So it's not an external sound that you're perceiving inside your ears. And people describe their tinnitus in many different ways. Most commonly, patients report a buzzing or a ringing sensation, but it can also be a whooshing or a low frequency hum. And if any of you are suffering from tinnitus and it's either unilateral, so in one ear only, or it's asymmetrical, so it's worse in one ear than the other ear, then please do go see a doctor, because there can be an underlying cause or several underlying causes. The one that as an audiologist and GPs and ENTs are always slightly concerned about is a pathology called an acoustic neuroma. It's also known as a vestibular schwannoma. And a vestibular schwannoma is a benign tumour that develops on the balance nerve. Now, the balance nerve encompasses the 8th cranial nerve, also known as the vestibulocochlear nerve or the cochlear-vestibular nerve. So it contains both the auditory nerve, the nerve of hearing, and also the nerve of balance. And if this benign tumour develops and grows, it can start to compress against the auditory nerve and not only cause tinnitus in that affected ear, but also vertigo. Some people also veer to one side whilst walking, or they experience disequilibrium. Some patients can also experience facial numbness, because the facial nerve, which is the 7th cranial nerve, also runs deep in the ear, in the internal auditory meatus. So if it's extremely large, it can also compress against the facial nerve. So now there could be a straightforward reason. It could just be earwax. Some patients may have other pathologies which are not as worrying for audiologists or ENT or doctors, such as otosclerosis, which is a stiffening of the stapes bone. So in your middle ear, we've got 3 ossicles, so 3 middle ear bones. And the smallest bone of them all, the stapes bone, which connects to the organ of hearing, the cochlea. In patients who suffer from otosclerosis, they have this abnormal spongy bony growth that develops around the stapes bone, and it fixates the bone. So when the sound hits the eardrum, normally what should happen is that the eardrum should vibrate, and these vibrations are transmitted through the 3 bones, and it causes the stapes bones to move forwards and backwards. And that hydraulic action causes fluid contained within the cochlea, the organ of hearing, to travel in waves over microscopic hair cells. There's tens of thousands of microscopic hair cells contained within the cochlea, the organ of hearing. And there are sensory hearing cells. So when this fluid travels in waves over these microscopic hair cells, it causes these microscopic hair cells to shear side to side and to contract. And that produces an action potential, so basically an electric current, which is then transported up the auditory nerve to the brain, where it's perceived as sound. But when you've got otosclerosis, because of that abnormal spongy growth, that stapes bone is fixated, so it no longer vibrates, and it actually causes ossicular fixation, so it stiffens all the bones, and it makes the eardrum extremely taut. So when sounds hit the eardrum, because it's so taut, it reflects the sound waves out of the ear instead of absorbing it. So it can lead to what we call a conductive hearing loss. So A conductive hearing loss is when sound waves can't travel efficiently through the ear canal or through the middle ear, so the eardrum and the three bones. So yeah, tinnitus can be for a number of reasons. It could be some side effects to some certain medications. It could be related to stress, fatigue, hearing loss itself. There is a link between hearing loss and tinnitus. So one theory is that everyone really suffers from tinnitus. And I'm trying to explain this in a more simplified way, but everyone suffers from tinnitus. But when you've got normal hearing, even if you're in a quiet room, there's an ambient noise floor which can mask the tinnitus. But when you've got a hearing loss, you may not be hearing some of the ambient noise floor in the room. So your brain then switches attention to the tinnitus itself. So do get it checked. In addition, if you suffer from pulsatile tinnitus, so it could be cardiosynchronous, so it's almost like a beating sound and it's synchronous to your heartbeat or your pulse, or sometimes it can be non-cardiosynchronous. Again, please do visit your doctor about that, because there could be a plethora of underlying causes that require further assessment. For example, you could have a blocked a carotid artery, so the blood flow is kind of restricted, and you can hear the blood trying to get through the artery. You could have a glomus tumor, which is a tumor that develops in the middle ear and can compress against the eardrum. Typically, we can normally see that when we examine your ear. So yeah, please do. Now, if you suffer from tinnitus and it's in both ears and it's symmetrical, it's not typically a referable condition. It's not something that we classify as a red flag symptom and then warrants further investigation. But nonetheless, I would still get your hearing checked and your ears examined, just to rule out something simple like earwax, or you may have an infection of the ear as well. So, and all of these things can lead on to tinnitus. Please don't ignore it if you have tinnitus. So in this particular case, because this patient's tinnitus is quite severe, we did manage to extract all this earwax using the Curette. It was quite difficult because they have got really a narrow ear canal entrance and they've got loads of hairs, as you can see. But this is where the angled right Curette really assisted me, because it gave me more maneuverability. It was easier to insert in the ear. Now, this patient does have to attend on a regular basis, I think 4 times a year, so they are a chronic wax sufferer. And I do typically advise the patient not to use any drops prior to attending, because if this wax was a bit firmer, it probably would have came out a lot easier. But because it's quite soft and wet and loose, it took me a while to remove, but we got there in the end. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.